Hello, I'm Smith. I'm a registered nurse, and my evidence-based practice subject was the prevention of pressure ulcers in the acute care and long-term acute care setting. Pressure ulcers were identified as a common complication of immobility amongst the elderly, which is very common with old age. You see increased risk for fall due to different disease processes. So it poses a greater risk for them. And then an average of $15,000 is spent in hospital stays when someone does fall out of bed in the hospital. And then a study that I reviewed said that patients were only frequently repositioned 53% of the time, based on 187 out of 354 index visit days. So that is a very alarming number. And then insurance got hip to that, and as of 2008, Medicare will no longer reimburse for hospital-acquired pressure ulcers due to just people being in bed and being immobile and not being turned properly, because it is assumed that you can prevent pressure ulcers. All right, so the objectives that I'll cover during this presentation is that we will identify 3 ways to implement the current pressure ulcer prevention bundles in our facilities, and the nurse will be able to describe 2 recommendations from the prevention guidelines on how you can, how they are effective in current practice. And then we'll just go over some practical ways on reducing incidents. So objective 1 pretty much outlines what's going on currently in current practice versus what actually happens. We know sometimes we're on the floor, we get a little busy, and that patient who could get turned every 2 hours, it may not happen for 3 or 4 because we're caught up in, orders, and the techs are caught up in other rooms. So current practice is bedbound patients are supposed to be turned every 2 hours. Assessing skin thoroughly at your head-to-toe assessment. Now we know when we get a patient at admission, that's an automatic, like we have to do that. It has to be documented. If they have pressure ulcers or their skin gets checked and we see certain things, we have to call skincare, and then skincare has 24 hours to come in and look at them. So there are different policies and procedures that happen when a person is admitted, but then during that person's stay is where that breakdown, no pun intended, begins to happen, whether it be breakdown in communication or a breakdown in quality of care because we get so busy and so caught up. And then actual practice, what's real versus what actually happens, and then a head-to-toe assessment. So let's talk about who has time for that. On average, how much time do we spend doing a head-to-toe assessment?
5 to 10 minutes.
5 to 10 minutes, okay. And do you round hourly on your patients?
Yeah.
For the most part, okay. But I mean, if we're being honest, we can say it goes. I mean, unless they need pain medication or something immediately, we're not really running back and forth in there every hour, because sometimes in the run of a day it gets so crazy it's just not happening. And then if you're not able to round hourly, they said that ACPs, you or the ACP should be rounding hourly. So if you don't get a chance to go in there, do the ACPs know what to look for when turning patients and reassessing skin? Like, are they looking at their bottom? Because I know sometimes my ACPs come and get me and say, hey, have you looked at their butt? Like if they're turning them or cleaning them up, and I'll run in there like right then. I'm like, okay, because I might not have gotten to do that at my first head-to-toe assessment because I was just trying to get their pain meds and get them situated for the day, set breakfast up. So I'm not even in that mode, thoroughly until they have an accident or they need to be cleaned up, and I'm like, okay, let me look at their skin. But on first glance, at the beginning of the shift, sometimes it doesn't happen for whatever reason. And do ACPs inform you when assessment findings deviate from the norm? Yeah, for the most part. All right, so this is just a small, and it might be a little hard to see, but risk factors for identifying people who are at risk for pressure ulcers. They go from aging, and like I talked about, chronic disease processes. So in that list, they have diabetes, peripheral vascular disease, things of that nature. because diabetes enables their ability to heal effectively. Impaired mobility, did they recently have hip replacement surgery, or did they fall down and break a hip? Like, is that a factor? Malnutrition, and we know sometimes with the elderly population, they get into the habit of not eating as properly or full meals, or they get full very fast. And in their mind, oh, I had a bowl of soup and some crackers earlier. Well, it's 8 o'clock p.m. and that's all you had all day. So they don't even really think about, oh wow, I haven't eaten that much. And then, and those are all intrinsic factors. When we talk about things that sometimes aren't preventable, but extrinsic factors being pressure, friction and shear, like, pulling them back up in bed, and moisture from them having incontinence. And a lot of them come in and they automatically want to breathe. Like, if they come from a nursing home, they're going to tell you they want their breathe, or they want to get a Foley in while they're in the hospital, because they know they're going to frequently go to the bathroom and have accidents. And then a lot of them will refuse their laxatives. I've seen a lot of them do that. Like, if they come from a nursing home and they've been getting their laxative every day, when they come to the hospital, they don't want their laxative, because they don't want to have to be in a position where they're not being changed as frequently, because they know their habits. 2 recommendations from the guidelines. So when I looked on the website for the different guidelines, when we identified in, I think it was EBP, either 2.1, where they talk about implementation, observation, and monitoring, and also education. And we know education is a big thing, because sometimes people don't know what to look for. Like, they may think that red spot is just a bruise, and they don't remember bumping themselves, but that could really be a pressure point. And then I have some pictures in later that show like high risk pressure areas. So implementation of this in a practical way looks like, okay, perform a complete skin assessment every shift. We all know that. Assess skin regularly and cleanse properly at time of swelling. We all know that again, but in the hospital setting, we kind of depend on our techs to do that. And if that tech is in a hurry, or if they have 5 or 6 other incontinent patients and they're rushing through, it may not get done as thoroughly and as effectively as it should get done. Also, monitoring effectiveness once you've cleaned them up. Observe the skin regularly for color changes. Again, that goes back to that bruising. Are they on blood thinners? Like, are they on heparin? Are they on Coumadin? Are they on things that are going to make them bruise a little easier? And can we tell the difference between a bruise and a pressure ulcer? That's why that skin assessment at beginning of the shift or at admission is so important, because if it gets acquired, once they get in those hospital doors, insurance is not going to pay for that. And your hospital is going to be looking pretty confused, like, why are we paying all this money for people who are here acquiring pressure ulcers? So you'll see that increased rate. And then you educate the patients, educate caregivers and ancillary staff. Because again, the family just freaks out and brings them to the emergency room. They haven't had time to look at their skin. They don't know if grandpa had that bruise on his bottom before he came. He might have fallen, or they don't know, because sometimes I can say from experience, elderly people have fallen and they don't tell anyone. Like, they kind of get up, brush themselves off, so they'll have scabs or scrapes. You're like, where did you get that from? And like, oh, I fell a couple weeks ago. And they could have something going on beneath their skin and we don't even know it. And their family doesn't know. And then all of a sudden, grandpa gets a pressure ulcer and the daughter's freaking out saying, he didn't have that before he left home, when she didn't even get a chance to look for him, or she hasn't been as hands-on with his care, and she doesn't know the changes that have been occurring with his skin. So we have to be very, very careful with that. This one also, it just identifies the pressure point. So of course, like right back here, when they're laying in that bed and they don't really want to turn, or on the sides of their butts, the side of that hip, like just bony prominences. And we know older people do not have as much fatty tissue as younger people. And those areas are way more susceptible. And even up here, they didn't point it out on here, but like the backs of the hands, like depending on how they lay, like some of our older people that are contracted, I've seen pressure ulcers on the backs of their hands, just from being in that state and leaning on that pillow or leaning on that bed rail, and it just breaks down more and more. So we have to be careful with that too. and alterations in their sensory responses. Like, again, our diabetic patients with that peripheral neuropathy, they don't know that it's occurring. They can't feel it. And before they know it, they turn around, they lose a foot or they lose a toe. And then we also talk about alterations in mobility. All right, so the Braden scale, in my articles, a few of them touched on it, but one mainly touched on the Braden scale, which is the 6 elements that covers all the objectives when we're talking about pressure ulcers. So on our flow sheets at the hospital that I work at, it goes through sensory perception and acts. Is it limited, completely limited, not limited at all, or somewhat limited? So each one goes from somewhat to completely mobile to completely immobile, and it asks those 4 different things. So based on that score, once you tally all these up, I think there were 4 points each. So once you tally all of them up, if they're over 20, they're not at risk. But if they fall anywhere below 20, I don't care if it's 19, they're at risk for a pressure ulcer, and skincare is going to get a consult automatically. That's how it's done in all scripts for us. And then skincare gets a list generated, and then they come out and they say, can I see your patient and such, and they go around to each room. We have a whole skincare team at the hospital I work at. So I found this online, and I thought it was really key because it tells you how, like, the steps that you take. So you go through your admission skin assessment, including history. So that includes if they've fallen in the past. And ask them, if they don't remember, ask your daughter, has he fallen, has he scraped his knee? Like, you need to know. If they fell, period, fall. Fall risk, the end. That's it. Don't give them time to elaborate, because when you cut corners like that, it tends to blur lines. Okay, is there skin breakdown or pressure ulcers currently? If yes, you develop the care plan. Again, in our system, it's going to trigger skincare to come. If no, you assess it. You assess it daily. You just kind of leave it as is, and you kind of keep watch on it. In this case, you consult skincare, and skincare comes out and say, okay, head of the bed up, make sure their feet are raised, turn every 2 hours, incorporate pillows. They're going to throw some Baza in there. They're going to do everything to cover their butt for like a basic fall person. And then also, are there risk factors for breakdown? So this takes some critical thinking as a nurse to say, okay, what are they in here for? What's their history? Okay, do they have hypertension? Do they have diabetes? Do they have a history of peripheral artery disease? Again, all these things pose a great risk to them. Do they smoke currently? Do they have a history of smoking? Somebody, oh, I quit smoking last year, but I smoked for 50 years. You're still at risk. You're not out of the woods yet. So at risk is 15 to 18. Moderate risk is 13 to 14. So anything, like I said, anything below that 20 mark, you're at risk. And then you review outcomes of plan and interventions, and you still assess. And it's going to be on everybody's plan of care. So whenever we chart on that same patient, you'll see each row, the nurse has to go in and answer these same questions every shift. It's not just once a day, it's every shift. And then they also included demographic data, age, diagnosis, we talked about this earlier, comorbidities, admission trajectory. So how long they're going to actually be there. And then in the study I looked at, patients were to be followed for 2 days, for 2 days from admission through discharge for up to a maximum of 28 days. So this is in a long-term acute care facility. And then the Braden scale scores show that the majority of participants in both groups were at high risk for pressure ulcers. So based on this study, they took 140 patients, and they had 70 who they implemented each time, the prevention bundle, and then the other 70, not so much. So in that, I think it was like 11, they showed an 11% difference between both groups. And it was based on those demographics, comorbidities, and things of that nature. It was a really good article. So what they came up with between all the articles, pressure ulcers are preventable. There are tools in place, there are things that we currently do in practice that are to prevent pressure ulcers. And it's a practical solution, but what happens is we have time issues, staffing issues, overwhelmed issues. We have just busy issues to where we don't get to the patients and they're not getting the care they need. And then also having that collaboration and communication with the skincare team. I don't care how many times they get annoyed with me. I'm just like, this dude has a scrape, it's been bleeding. Every time we cover it up, it starts bleeding again. They need to know that. And that's a part of their job. And they're more like, something for my team, I can say, they're more than happy to come out and look at that person's skin. They have no problem with doing that. And even if they're walking in the hallway, it might not have triggered them, but I can say, you know what, I noticed this morning when I looked at him, he had such and such. Because the nurse 3 days prior might not have addressed it, and they might not even know. Would you mind coming in here and looking at this patient? Because at any rate, you would want to cover your patient. And just a brief little Q&A. What has been the biggest challenge during your career? And you can base it on your, I guess where you work or whatever. But answer either one of these questions. Do you feel as though you are not providing effective or quality care? What can be done to change this? Are you ready for the challenge? So I guess between question 1 and 2, you can answer either one of those. You included.
My biggest challenge is, I would say, time management. What could be done to change this? I guess collaborate more with the ACPs to, help me as far as, changing patients and not calling me every 5 minutes, And it also, just you take care of this patient, I'll go and see that patient, if any changes or if you see something that's not right, just let me know. And am I ready for the challenge? Oh yes. All right.
I would say, like, answering the second question, do you feel as though you're not providing effective or quality care? Sometimes I do because of lack of communication. It just like, I feel like I can't get things done in a timely manner because I'm waiting on somebody else. And so what can be done to change that? I think just addressing the issue with like people that are higher up than I am and letting them know that it's a problem so that it can be addressed. And I guess, yeah, I'm ready for the challenge.
Great. And that's it. So test time. Thank you guys so much for